The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Improving Sepsis Care, What's Working, What's Not. This presentation is sponsored by Wolters Kluwer. Wolters Kluwer provides trusted clinical technology and evidence-based solutions that engage clinicians, patients, researchers, students, and the next generation of healthcare providers. More than 6.5 million clinicians use Wolters Kluwer's expert solutions to reduce the variability that stands in the way of effective care every day around the world. Solutions include UpToDate, Lexicomp, Sentry7, POC Advisor, among others, to deliver the best knowledge and evidence into the hands of the people who need it most. Before we get started, I'd like to go over a few items so you know how to participate in today's event. By default, you've joined the presentation using your computer speaker system. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will also have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded, and you will receive a follow-up email within 48 hours with a link to view the recording and a copy of the slides. Now, I would like to introduce today's speakers. First, we have Dr. Itay Klaz. Dr. Klaz is the Medical Director for Clinical Surveillance and Compliance, Wolters Kluwer Health. He is responsible for directing clinical efforts toward the development, implementation, and support of Wolters Kluwer's suite of surveillance solutions, primarily focusing on POC Advisor. Dr. Klaz is a clinical informatician, dermatologist, and a former military surgeon. Next, we have Karyn Wentz, Nurse Informaticist for Clinical Surveillance and Compliance, Wolters Kluwer Health. Karyn has 15 years of nursing experience in the areas of pediatrics, pediatric hematology and oncology, women's services, infection prevention and control, and informatics. She has worked in both teaching and community-based hospitals, which contributed to her deep understanding of clinical workflows. Karyn is passionate about the implementation of clinical decision support tools to improve health outcomes of patients. And Dr. Klaz, I'll hand it over to you.
Thank you, Sarah, and hello, everyone. So today we'll be discussing a couple of key elements that stem from the fact that Karyn and I work with sepsis teams across the country and have identified during our work here together some key areas that hospitals are hoping to address to drive performance improvement. We will talk through some of these challenges and best practices for solving them today. These would include elements as rapid response teams and sepsis response teams, and how do you coordinate these? The variation of sepsis care that we see across multiple institutions and even within the same facility, and the response team coordination that has to do with those variations. Discrepancies in sepsis identification. We know that this is one of the pain points, especially for patients who develop sepsis when they're already in the hospital, not on presentation. Then we're going to look at some suggested solutions, how to maximize our ability to surveil, to monitor, and to treat sepsis correctly and within the timelines of the SEP1 bundle as defined by CMS. And we'll talk about centralized view as one of these solutions, and then we'll finish up with balancing the sepsis care needs and antimicrobial stewardship guidelines, which we know is a challenge for everyone, and sometimes could coincide with the very wide spectrum initial care that is required according to the sepsis protocols. So how do we escalate and how do we move on from there? We know most of you on the call already know this, but let's level set before we dive in. A little bit about sepsis. So sepsis remains the leading cause of hospital mortality, even in days of COVID. And one in 3 patients who die in hospitals die due to sepsis. Patients with severe sepsis have a very high mortality rate. They spend much longer time in the hospital and especially in the ICU, and they are much more expensive and resource intensive to treat than non-septic patients. Beyond the obvious impact on patient mortality and morbidity, the financial cost to US healthcare is estimated at a staggering $33 billion per year, and it keeps rising. The average cost per hospitalized patient ranges from about $18,000 to over $50,000 per case present on admission. And if we're talking about inpatient development of sepsis, the numbers go even higher. So this puts the burden back on your hospital to manage this throughout, especially throughout what we're going right now with the epidemic or pandemic. Now, this is a view of what we call the point of care advisor, which is a Walter Kluwer's comprehensive sepsis solution to identify patients at risk faster, and beyond that, to ensure that the care of the patient and the compliance with the requirements of CMS and the SIP1 bundle carried through regardless of where the patient is right now at the hospital, whether they're at the ED or they're waiting for a bed in the unit. Maybe they just passed PACU and about to go back to the unit or even to the ICU. And those patients that are just kind of lingering in a med-surg unit somewhere down the hall and develop sepsis often very rapidly, but do not have the resources and the clinical team capacity that patients in the ED have, and therefore are much more susceptible to be missed when we try to identify sepsis early. Now, our approach is to go and attack that whole sepsis management by using 3 elements. One of them is to integrate point of care alerts right at the EMR as organic as possible to the EMR, and it doesn't really matter which EMR it is, but to produce alerts, reminders, notes, bleeps that actually meet the criteria of sepsis or give you the heads up for a patient who is about to decompensate, but are also very tightly integrated into existing workflows and systems. Not another add-on element or system that you need to learn or change your the way that you practice, but full integration into the existing tools of whichever EMR you have. The second element is population monitoring, because as we know, sepsis can hit every patient in every department and in every stage of their episode of care. So we believe that a centralized dashboard or monitor, some sort of a control tower, is a very helpful tool in managing the entire institution as it regards to sepsis, from identifying the most critical cases that need immediate intervention to oversight on the ongoing compliant care for the patient that are already started their septic journey, but we want to make sure that they're getting their the appropriate care steps and the appropriate timeline. And as we know, the timeline for CMS, at least for the SIP1 bundle, is very restrictive and talks about pretty hard cutting points like 3 hours, 6 hours, etc., depending on the patient's level of sepsis. And then the final element that kind of closes up this entire suite of solution is to have the right data reporting and analytics that would allow us to take all this information and knowledge that is accumulated beyond the individual patient, but also at the population base, and dig into the compliance levels of different units, different care settings, different providers, and we can go all the way down to the individual patients. This is a very important tool that allows anywhere from senior management to a pod charge nurse to get a full sense of what is happening and what has happened and what needs to be addressed. Now, our first topic here, as we're talking about how do you deal with sepsis on the ground, would be to talk about the rapid response teams or sepsis response teams that have been proliferating lately across the country. Some places still have them in transition. Some already have very well established teams like that and protocols and procedures to activate them. But that is not always the case. And we know that there's quite a considerable struggle in establishing such a program that would actually provide solutions in real time to those patients that are rapidly decompensating. And for that, actually, we have the first poll for you guys. So I'm going to put it on here. And Sarah, why don't you, or Jay, why don't you take us off on the poll? Okay, I can see now that the poll is open, and you will give you guys like 30 seconds, something like that. So if you're interested in voting, that's the time. Okay.
All right, great. So it looks like we have 87% of the responses do have rapid response teams or something of the sort. So that's great.
Terrific. Okay, great. So now that we've established that, and this is really one of the crucial elements at the end point of care that we see as really moving the needle, if you may, towards better care and rapid care. Let's look at our next one. So, in your hospital or facility, here's another quick poll for you guys. Who actually coordinates the sepsis efforts at the facility level? And we put here a couple of options, so the poll should be open now. You're welcome to cast your votes. This might not cover all the different solutions that facilities have, but it's a starting point. Okay, folks, so do we have the outcomes already, Karyn?
Yes, we do. We have 54% of respondees said that they do have a sepsis coordinator, with 41% having sepsis efforts handled by quality. So, and then of course 5% with each department managing. So that's a great start, having someone specific to handle those coordination efforts at your facilities.
Absolutely, and I must tell you that I'm very pleased to see these numbers, because as we work with facilities across the country, sepsis coordinators are taking a much more important role now in almost every mid to large size facility. And we know that the recruiting efforts are complex, finding the right person is complex, but very good to see that seems like at least half of the folks here on the call already are familiar or in the process of creating that position and having it as a central part of managing their sepsis program. And I'll switch now to Karyn to talk a little bit about the rapid response team and sepsis coordinator from a broader point of view.
Great, thank you. There, as everyone is aware, there can be several different models for our rapid response teams or medical response teams. The majority of the models have dedicated departments or staff members that respond to those rapid responses, such as charge nurses or other designees from the ICU, ER, it can be hospitalists, designated residents, if it is a teaching hospital as well. Also having nurse leaders or nursing supervisors respond to help facilitate organization of that rapid response is very helpful as well. Having someone to manage who's going in and out of the room. Does everyone have the appropriate PPE? Do we have the supplies needed? Making sure that everyone is assigned a specific role to be able to foster that communication and run that rapid response smoothly. There are some facilities that have rapid responses specific to sepsis, which can also be valuable. Sometimes the members of the rapid response team and sepsis response team are very similar. Other facilities can bring in other subject matter experts that can lend some expertise in responding to that sepsis case and making sure that all aspects of that sepsis bundle are being completed, and also offer suggestions and some other clinical-based evidence on how to treat that particular patient. Other facilities also have a family-initiated response team, which is a great resource, especially in times where staffing could be challenging. We're short-staffed, we have an increase in the number of patients, we might have extremely sick patients where we're in that patient's room and can't necessarily get to another room in a quick manner. So having that ability for families to notice when their loved ones are decompensating or something just isn't right is a great option for facilities to have as well. In addition, sepsis coordinators are a great resource for organizations. They have the ability to not only retrospectively review sepsis cases, but also review potential sepsis patients in real time, which can help foster that communication with providers and other frontline staff to make sure that we're doing everything that we can for the patient and that they're getting the care that is needed. They're really great about helping to identify opportunities within the organization to ensure that the SEP 1 bundle compliance is met. So what areas are we doing great? What areas do we need work on? And let's focus on those. And oftentimes quality can get involved in that aspect too, just to help make sure that we are following a great process and really working towards improving outcomes for patient care. Also, they're a great resource for education for our new nurses that are coming into the facility, new graduates, and also just any type of continuing education care that a facility needs. So, you know, education doesn't always stop when you come into the facility, but we need that ongoing education continuously to make sure that we're doing what we can for our patients and getting the education resources that we need as well. Shortages have really brought a need out for those sepsis coordinators. So it's great to see that over half of the respondents have one of those in the facility. As everyone is aware, healthcare worker shortages are prominent across the United States, with many departments working short-staffed, working longer hours and additional days to help cover patient needs. So having that sepsis coordinator can be a valuable resource to ensure timely identification of septic patients. And having a centralized dashboard can also assist with that effort as well to make sure that we're identifying those patients in a timely manner and can help prioritize sending out sepsis response teams and to help identify patients before they actually decompensate.
Great, thank you, Karyn. So we're now going to go into a little bit more in depth about and let's start with the discrepancies in sepsis identification. So as we know, sepsis is a tricky beast. It could be very rapidly progressing. It could be a patient that has seemingly been pretty stable but is now starting to show some signs and symptoms of an impending septic event. And if you actually collect the vast amount of data that we have today through the EMR, through automated vitals, through rapid labs, for example, and rapid radiology responses, there's actually an opportunity here to take into account and analyze, synthesize in real time all these various sources of data that keep flowing into the EMR and eventually for us, the clinicians, but to get a tool that would help us make sense of all this data and do it in real time. And I would actually switch us now to another poll. Yes, this session is very interactive, as you can see, which would ask you guys about how do you actually identify those patients, or the patients that are starting to decompensate or maybe have the higher risk of decompensation. So I'm going to put that poll up, and again, folks, use your keyboards and use your poll. Okay, so Karyn, what do we see from the results so far?
Okay, great. So 83% of respondents said that they have an EMR integrated risk assessment scores and alerting. 5% have a third-party sepsis solution. 51% also said that they have a manual or nurse-dependent sepsis tool. And then both 7% use population management tools or rely on just clinical judgment or other ad hoc components.
Terrific. So this is actually, these are also great news, because we have seen in recent years the, I would say, plethora of solutions that are out there in the market, starting from the EMRs themselves, who are providing different models of risk assessment for sepsis and follow up on it, to third side vendors, which offer add-on solutions by utilizing the EMR data, pretty close to what we're doing now here at WK, at Wolters Kluwer, which is to take all that data available within your EMR and then synthesize it, analyze it in real time, and produce suggestions, assessments, and maybe predictions for septic patients, often much earlier than the clinical team would notice, especially a very busy clinical team like we've all been in the last 2 years. Now, the early and accurate sepsis alerts are almost a pie in the sky for many, many systems, and as I'm sure many of you are aware of. We know of specific risk areas in the hospitals that may need certain extra attention or additional focus when we want to identify those septic patients as soon as possible. One of the most critical areas for these fallouts, for the patient who just gonna find themselves in a bit of a limbo, are patients in transition. So that could be a patient who is waiting for a bed or for transportation from the ED to the floor. Maybe someone who is already post-surgical, first day or two were fine. Now they're recovering at the end of the haul, but starting to rapidly decompensate. And these patients actually present the most complex challenge for early identification. The ones that come with sepsis present on arrival to the ED are usually identified. ED providers, ED nursing staff are very savvy and familiar with the signs of a septic patient on arrival. The problem is usually when the patient leaves the ED to the next station, either in a holding pattern, as I mentioned before, for either a bed or transportation, or in a sense, they've already been covered. The orders have been put in, everything should be going out according to protocol, but then we know life takes over. The ED becomes very crowded. The teams are running back and forth, and that patient who is seemingly already okay, they started their journey or their septic bundle treatment, actually decompensate, deteriorate. Maybe they need to move now to a higher level of sepsis care, but the attention of them is right now not too focused, since we all kind of put it in our mental boxes as they're already being treated, they're okay, they're just waiting for a bed. And this is where we see the biggest fallouts of decompensation, even rapid decompensation, all the way to what many studies have shown, that missing the diagnosis of sepsis by 1 hour is the equivalent of about 8 to 10% increase in mortality. So crucial points that has to be addressed. Now, what about the alerts themselves? So alerts is almost a misnomer, I guess, but alerts do have some critical elements to make them efficient and usable. We also have many types of alerts that do not meet those criteria. For example, generic risk scores. When you look at the DAR, or when you look at the patient, dashboard, and you see one of the 10 or 20 columns of data that appear there on the screen, would have a red label that says this is a patient with an increased risk predicted for sepsis. And that comes from some sort of a generic mechanism that looks at basic serious criteria and maybe organ dysfunction, and then triggers this kind of alert or notifier. We also have increasingly more and more solutions that are purely dependent on machine learning and artificial intelligence. Now, these are very exciting developments, and of course, they give us the opportunity to identify, to treat, to select better care beyond what we were able to do prior to these technologies. However, they also carry a significant challenge of what we call the black box challenge. In other words, for those not familiar with the term, when a provider or a nurse sees an alert that says, according to our algorithm, this patient is about to decompensate or is in a state of severe septic shock, but there is no explanation that goes with that. There's only an alert that is generated by a sophisticated algorithm we're not familiar with, we're not aware of. By the way, even the designers are not aware of, because the idea of machine learning is that the logic is internal. We know what goes into the box and we know what comes out of the box, not exactly how the decision was made. So when providers and clinicians see these kind of alerts that have no clinical immediate explanation attached to them, unfortunately, what we see across the country is a tendency to either disregard them or put them in kind of a lower priority. Now, add to that the lack of specificity of many alerting systems today that would fire an alert or raise the flag for almost every patient that steps into the ED, because they have two source criteria and maybe something in their history or currently gives us the notion or the suspicion of infection. That would actually raise the flag in most generic EMR systems, at least. And we know that the sensitivity is very high. we will be catching all septic patients this way. But what about specificity? In other words, how accurate and how trustworthy are these kind of alerts? Because if we look just at search criteria, which are the base for most EMR generic alert systems as we know today, we will have a sensitivity that is very high, but the specificity tends to be under 20%, some of them even lower than that. Now, what does that translate to? In simple words, it means that only 1 or 2 out of every alert are correct, and the other 8 are not. Now, I'm not sure about you folks, but at least where I worked as a clinician and was on the floor or the ED, if an alert or a pop-up came from the EMR and was false more than 2 or 3 times, that was pretty much it for me. And there are actually a lot of studies now that have shown that providers have a very low threshold to reject these kind of systems when they're so highly unspecific. The numbers even talk now about 3, as we give you 1 chance, 2nd chance, 3rd chance. The alerts were all false. Therefore, I'm going to disregard all the rest. And that creates a real risk, not only for those patients that are maybe treated inappropriately, but also for the patients who have true sepsis. As clinicians start ignoring these alerts and regarding them as just background noise, basically, due to their inaccuracy or lack of explanation, being a black box kind of alerting system, we actually start missing real cases. That's when it becomes a significant risk factor. So let's jump from here to the protocols and procedures. Or in other words, how do we actually treat sepsis? And do we have standard protocol? Do we have standard workflows? So I'm going to put in another quick poll here. Just a yes, no kind of question. And let you guys chime in. Okay, so Karyn, what are we seeing?
Great news. 95% of respondees utilize standard sepsis order sets across their facility.
That's terrific. And I would go even further than that, beyond that poll. Having an order set for sepsis is something that is almost a given, especially since at least the major EMRs have it as a built-in component in the package that you receive when you install, Epic, Cerner, Allscripts, Meditech, etc. The problem with many of these bundles or order sets that they are not patient-specific, sometimes not even department-specific, and they're also often not updated and tracked to meet the exact changes or what is going on right now in the field of both sepsis and specific biograms in your institution, in your facility. So if, let's say, for example, some of you might be aware of it, but CMS is now about to release another update to the SIP1 bundle compliance definitions in January, which would somehow give more flexibility to clinicians in certain elements of the bundle, especially around fluid volumes. When that comes out, and these kind of updates tend to come out a couple times a year, and then the occasional ad hoc ones as well. Who takes care of updating those order sets that are across the institution? Especially if you have an environment that allows individual providers and or maybe units to tweak and customize those bundled sets to their specific needs. And that is all great and of course good for targeting specific contexts and situations. But when changes in policy or in FDA recommendations, maybe one of the professional societies puts out some new suggestions for protocol, who actually takes care of making sure that all the existing order sets and bundles across the institution are updated correctly and now meet the new or changed criteria. And I'm going to pass here again to Karyn to talk about how do we go from here to the larger goal, the greater goal, which is we want to decrease the variation of care when we talk about sepsis.
Yes, as Dr. Klaz mentioned, making sure that those order sets or clinical guidelines and protocols are updated when there's any changes to the guidelines can be extremely challenging. I know we've mentioned several times throughout the presentation about staffing shortages and having someone to handle those sepsis protocols. So in some of these organizations, it can be extremely challenging depending on what resources you already have established versus things that you're currently working on establishing. So having a clinical governance in place to manage those sepsis protocols can be extremely valuable. Having that systematic approach to making sure that these order sets and protocols are being updated in a timely manner. So that may mean making sure that we're maintaining compliance with committee meetings to ensure that the approval process goes smoothly. Across organizations, often order sets, any changes to policy need to go through several different committees for approval before they can actually be utilized. So when there are those changes, are we aware of, when is this committee meeting next? And can we make sure that we're on the agenda to make sure that we have the all key stakeholders really weighing in on these changes? It can also be helpful to have a sepsis-specific committee that can be continuously reviewing updates to the guidelines and can work with other departments to ensure order sets and other protocols stay up to date. Sepsis coordinators, again, are great for this because they are the true subject matter experts in regards to sepsis. So you're often very familiar with, when these guidelines are changing. There's that update coming in January. So how can we be prepared for that and make sure that our order sets and protocols are up to date as soon as possible after those changes go into effect? One of the most important things that an organization can do is have executive leadership backing. It can be really useful in making sure that we can escalate any potential issues or potential for missing deadlines. Having that strong executive leadership on that, who's very passionate about sepsis specifically, can really help us move the needle per se and really get that work done and making sure that we're all coming together for the common good of the patient. It's truly a game changer having that support and can provide not only that leadership backing, but provide you with the support that you need to make effective change within the organization. It can also help to have that communication between nurses and providers, getting feedback at the nurses station on, what can we do to make this process easier for the ultimate end user, and then taking that information back to the appropriate committee or appropriate sponsor so that we can really implement those changes that not only are effective for patient care, but can also help make the system and protocols more user-friendly, because the easier that they are to use, the more they're going to be used, which is ultimately the goal.
Thank you, Karyn. And let's look now at the next element we mentioned at the beginning of this webinar, which is utilizing a centralized, focused clinical dashboard or view that would help us to gain an oversight of what is going on in our facility from the ED to discharge regarding sepsis. And we know that this could be a real challenge, even if you do have a sepsis coordinator in place or a couple of them in larger institutions. Their ability to monitor in real time what is going on across the institution when you talk about hundreds of beds and very stretched to the limit capacities we see in the last year or two. A centralized board like that becomes essential in managing and prioritizing how we deal with sepsis, how we triage the rapidly decompensating ones that would need maybe a rapid response team, and not to forget, how do we keep an eye on the ongoing adherence to the protocol of the patient? Beyond the first order entry or the first order set that went in, how do we make sure that this patient who just, let's say, was transported from the ED to a 3 North, a med-surg unit, is still going to be treated according to the severe sepsis bundle, for example, within the timeline of the bundle, despite all this change of care, handing off of the patient, setting them in, having the intake process, and all that procedure, all these procedures that take place between the time that they were last assessed by the clinicians and given some protocol or orders to when they're back to, I would say, a supervised position and completed this transition or transfer phase. And this kind of board is, we see it as critical in helping managing the entire enterprise. And I want to bring up, I think it's our last poll, or maybe one more after, which would ask you, how do you actually view the information that you get for the entire septic population in your hospital, and how do you accomplish it today in the means that you have in your facilities? So go ahead and vote, and we'll continue right after. Okay, so Karen, do we have, what is the jury saying?
All right, so 33% of respondees said that nurses complete regular sepsis assessments. We have 28% that look at each patient individually in the EMR. And then we have 25% that have a dedicated sepsis dashboard. 8% use other means, and then 6% say that they actually have the sepsis coordinator doing rounds on the floor. So a great mix.
Great mix, and a good reflection of what we see on the ground across facilities. I think you folks mentioned the nursing assessment and the sepsis coordinator as being maybe, I think, the leading solutions that you have, if I got it correctly. Both of them are actually not using a centralized board in that sense, but are more reliable, rely on doing the rounds, touching the patient, going to the department, going to the floor, going to the ED, and basically manually monitoring what is going on. So in order to provide the folks who do these oversights, monitoring of septic patients across the institution, that's where we see the real need of a centralized dashboard. And what you can see here, again, is an example from the Walter Kluwer's point of care advisor, or POC-A, which we've mentioned before, the centralized dashboard that we call Care Monitor. This is here kind of in the center of the slide. You can see here a monitor that is dedicated to septic patients, all the way from the top here where you see those patients marked in red. These are patients that the system has already identified as having either an imminent or very close, or actually started down a septic road, but there's no clinical awareness of it yet. In other words, no one has put in orders or a diagnosis or related to this information. The more critical part would be what we call here the active workups, which lets you follow each patient, regardless of where they are in the institution right now, in real time, and follow the care path that they're being treated on. So in other words, if a patient is right now under the sepsis protocol with hypotension, that requires about 5 steps that are defined by CMS protocol, but it also has a very restrictive timeline, to take.
Hey, Itay.
Yes.
Sorry to interrupt you, but I think we have an issue. It seems like some of the folks are still seeing the poll. So I wanted to just pause quickly and see if we could troubleshoot so that we could make sure that your screen, everyone can see your screen here. So
Okay.
it's a great screenshot there. So let me see. I think we're kind of playing in the background. Sorry, folks. Bear with us here. There's always one technical difficulty.
Yeah.
And maybe if you try to stop sharing and then resharing, that could be an option for troubleshooting.
Okay, let me try that.
There we go. That did it.
Got it back.
If anyone else is still having issues or seeing the polls, please let us know. But it seems to be back up and running. So thank you.
Excellent. Thanks, Sarah. So for those who were seeing the poll as I was talking, just another quick mention. What you see here in the center of this slide is a care monitor, the way we call it, Walter Kluwer's. You could have different names in different systems, of course, but basically a dashboard that allows you to see in real time what is going on across the institution, both in patients that have not started yet septic care, but the system is giving us the heads up that someone needs to take a look at them, to the patients that are already being treated, and that you can see here an example on the right side for one of these patients. Do we have all the steps of the bundle being carried out in the right order and in the right timeline, from the first lactate to their vasopressors, depends on their situation. Of course, we all know that giving antibiotics, especially those broad spectrum ones we use for sepsis, and then taking the blood cultures, tends to miss the point, because we would usually get the sterile cultures. So it's very important here to keep it both sequential and to meet the timeline of the bundle. And we see that as a real advantage of having this kind of a centralized board in whatever configuration you have it. And now we're going to move to our last topic here, which is a bit of a multidisciplinary issue. We all struggle to keep to our antimicrobial stewardship guidelines. We know that the ascent of resistant strains is a real issue across the country, especially with hospitalized patients and patients that come from care facilities and sometimes are under long periods of antibiotic care. But then we get to this dilemma that sepsis care requires very wide range antibiotics at the get-go. So how do we make sure that we do the right thing at first, but as soon as we get enough data that allows us to de-escalate the level of antimicrobials, we actually do that. And we know that if we don't have this kind of connection between looking at our antibiotic usage versus treating sepsis, we're in a world of a whole lot of pain sometimes. For example, we know that almost 50% of patients with sepsis in the ICU develop acute kidney failure or any kind of other renal insufficiency that might end up in dialysis on premises. And often enough, this is not a result of their septic condition, but actually a kidney injury due to the very aggressive and wide spectrum antibiotics, just to mention one, Vanco as being, a chief suspect. What do we do with the patients that have already started their broad spectrum antibiotics, but then we get some results back, maybe from rapid protocols at the lab that tells us, hey, we identified the pathogen. So what do we do now? Do you have it in place, the procedures and the protocol, to make sure that as soon as possible, we de-escalate the level of antimicrobial care and meet both our AMS objectives and also protecting the patient from the potential significant side effects and comorbidities that can develop from using those very wide spectrum antibiotics. And here I'm gonna give you our last poll for this meeting. So let's see, how do you currently de-escalate antimicrobials for septic patients? So go ahead, folks, and vote.
Okay, it looks like our responses are in, and 62% of respondees do currently have protocols and procedures in place to de-escalate antimicrobials for sepsis.
Wonderful. These are terrific news, and I must tell you, you folks are in better shape than the national averages. But it is good to know that the procedures are there in place, and that it's an issue within focus, because it's very, very easy to miss that opportunity to de-escalate when you're treating a rapidly decompensating patient, and all we want right now is just to get them out of that whirlpool of sepsis deterioration. And think about AMS later. But in the long term and at the population view, we know that we're causing real damage, not just to the patient, but also to the resistance levels and the biograms of the institution. And just to show you an example of a patient, it's kind of a typical case like that. So we have a patient coming in with pneumonia, and there's definitely signs and symptoms of sepsis. She's feverish. The white count is going up. We're starting to see some elements of organ dysfunction. So that patient is rapidly decompensating into severe sepsis. What do we do with this patient? So we start with the protocol, the SEP1 bundle, according to what CMS defines as appropriate care. That would include the combination you see in front of you, maybe you guys use a slightly different one, but in all cases, these are very broad spectrum and highly risky antibiotics, especially to these patients that many of them are frail or already have some comorbidities that limit their ability to cope with the toxic elements of some of these antimicrobial protocols. So for that patient specifically, the ED folks took a mini bowel and that was sent to the lab. We got a rapid PCR protocol and actually identified strep pneumonia as the causative bacteria, at least the one that we know of at this stage and the most obvious one. So what kind of changes are we going to do to the antimicrobial regimen? So that's not going to be another poll. I'm not trying to put you guys on the spot. We de-escalated that patient to just a single ceftriaxone IV and observed good improvement. Patient became stable, and 2 days later we got the full results that actually confirmed the first rapid PCR outcomes. And that is an example of almost a daily occurrence in an ED somewhere across the country. How fast we can respond to this new information? Do we get it on time? Do the right people get the attention of this? And what happens then is a real challenge and requires this multidisciplinary approach, which I will pass now to Karyn to talk about.
Yes, thank you. The multidisciplinary approach is really key in helping de-escalate antibiotics appropriately. Having multidisciplinary rounds at the bedside or at a centralized location, being able to get the input of all team members, whether it be physicians, nurses, you have your nutritionist, you have physical therapy, and of course a pharmacist as well can be extremely key. Right then and there, you're having conversations about the patient, and based upon the patient's presentation, clinical symptoms, you can have a discussion with what is appropriate to de-escalate and when. So that is really key. Also having surveillance solutions in place, both for sepsis and pharmacy, can also be valuable. So to wrap things up, I know we've covered a lot of ground today with common challenges that hospitals are facing. So we've talked a lot about what's working and what's not. And I know we're coming to the end of our time, but we're definitely having our rapid response teams, having sepsis coordinators in place are definitely key aspects that are very helpful for any organization. And hopefully we can keep working on those standardized protocols and guidelines and to help us provide patient care and identify sepsis earlier.
Great, absolutely. So now we're at the end of our time, and you guys again will be getting this this deck within a day or two. So if we have any questions left, I know we have about a minute. Sarah, maybe you want to take us there.
Absolutely. Thank you both. This has been a great presentation. We are now going to begin answering some of the questions that were submitted during today's presentation. I know we're kind of right at the hour here, so feel free to ask questions if we don't get to them. We'd be happy to follow up with you after the session. So I'll start with the first one here, but just as a reminder, you can submit the questions through the questions pane in your attendee control panel. So the first question we have is, even if you have everything in place, a smooth running program, how has COVID-19 impacted the ability to treat sepsis patients in regards to antibiotics?
That's a terrific question. And we didn't touch too much on COVID, although it was in the background of this entire discussion when we talk about the lack of resources and stretching very thin. So for COVID, we have seen different approaches across the country in various institutions that we work with. Some of them have decided to treat COVID as any other sepsis. In other words, if the patient has the search criteria and we know that they're developing right now. They're going down the septic pathway. We will start the full protocol. Other places have decided not to go like this way because of the obvious unnecessary treatment for some of these patients that are purely COVID-based sepsis. And then once they get a rapid response or have an accurate, updated diagnosis of COVID positive, choose to treat these patients not by the sepsis protocols, but just to cover the physiological needs, as in fluids, vasopressors, etc., as needed. So it really depends. And also in the bigger picture, COVID has created such a stress and almost an inflection point in the way that we treat patients and see patients today, that many of these procedures and protocols that are been working great during, BC, before COVID, are now just not sufficient, not quick enough, not adjustable enough, and unfortunately, we've seen a significant drop in sepsis bundle compliance, excuse me, during the last year, probably due to COVID.
Great. Thank you, Dr. Klaz. We'll get one more in here and then we will say farewell. But another question here is, we saw a fair amount of people on the call have a sepsis coordinator in place, but for those that don't, how do you get buy-in from your team to invest in a sepsis coordinator?
I'd be happy to take that question. Truly having buy-in from a key stakeholder on executive leadership is really key. Somebody on the executive leadership team, they all have their own passions. And if you can find that one that really loves sepsis and wants to make a difference in that, become their friend and really talk to them about options that are available and how we can really push the needle and move things along with a sepsis program, and having their support will go a very long way.
Great, thank you. And thank you both again, and a special thank you to everyone for attending today's webinar. As a reminder, you will receive a follow-up email within 48 hours that will have a link to view today's recording of the webinar, as well as a copy of the slides. On behalf of Wolters Kluwer and our presenters, thank you for joining us today and hope you have a great rest of your day.